All right, we are at 5:31, so we will get going. Welcome, everybody. This is the Module 3 Zoom session. We have tonight your module leads, Dr. Jennifer Mendez, Dr. Abby Johnson, be leading you through the interprofessional teams. They have some presentation to do, and then they'll instruct you on how to proceed as far as the teams presenting their slides tonight.
So we will introduce ourselves while Mike's helping us just straighten out the last little piece here. I'm Abby Johnson. I am an assistant professor in clinical psychology. I'm a rehab psychologist and a neuropsychologist at University of Michigan. And my main role is to help provide services on the inpatient rehabilitation unit for our pediatric rehabilitation service as a psychologist. And so I'm helping talk about interprofessional teams today with Jenny Mendez.
Hi, I'm Jenny Mendez, and I'm an associate professor at Wayne State University School of Medicine. I'm so glad to be partnering with Abby on this. We've been doing this for about 3 years now, and it's wonderful to see her once a year.
Yeah.
But hopefully, I've been involved with interprofessional teams at Wayne State for the last 20 years. So this is one of the areas that I really enjoy doing, and I especially enjoy meeting all of you from all of these different universities, and hoping today that we can move on. So as part of our program today, we will be, next slide. We're defining interprofessional practice. Abby will be introducing the case to you, and you all have submitted your PowerPoints to us, so that's when you will be presenting to us. We will be discussing that, and then on the last few minutes, which will be around 6:20, 6:30, we will be discussing why interprofessional practice matters. Our next slide.
Hey, Jenny, can I interrupt you? Can you hear me okay?
Yep, we
Yes.
gotcha.
Okay, perfect. So you guys will be able to hear everyone now. So sorry to interrupt. Go ahead.
Perfect. No, you're good. Thanks. So all of you have received your instructions. Hopefully you've all had a chance to dig into the assignment just a little bit. The majority of this session is going to be our virtual team meeting. And so most of you are all part of small teams, and you all know what your team role is. But then there is one group that is called our leadership team, and they will be listening carefully to what's being presented, and they're going to help us guide the treatment plan for our case study of Jane. So we'll help direct how the discussion moves around, and we'll also be the timekeepers today to make sure we get some chance for discussion about this exercise after the fact. But we can go ahead and introduce the case briefly for you. And so we're ready for the next slide, yeah. So everybody should have been able to see this in their assignment, but just as a review, Janie is a 10-year-old with a diagnosis of autism spectrum disorder and intellectual disability who goes to her doctor for concerns of stomach aches and vague complaints of illness. She has a history of seizures that have been difficult to control, but she's been stable for the past 6 months using medication and a special diet. She goes to school with the assistance of an aide because of her risk for seizures and her difficulty with communication. Jenny also attends an outpatient rehabilitation facility for her therapies. She sees several different medical specialists, as well as has standard medical appointments and follow-ups, including dentistry and primary care. Jenny's family has been very active with the autism spectrum disorders community and is interested in helping children across the state. They have begun talking with different organizations who can influence policy for children with autism spectrum disability and disabilities at a broader level.
Next slide. So in terms of the focus areas, we had you think about yourself either as a patient on the team or members of the team. Maybe you were a teacher, maybe you were one of the family members. You each had to assume a role, and that would define whether you were functioning successfully as a team when you come up with the cases that you have submitted to us. The rules are, please, next slide. Don't break character, maintain the role that you were assigned, be respectful of communication, and give each team member at least 3 minutes to discuss questions with the rest of your members. So we want you to stay in character, not in the character that is your current professional activity, but the character that we assign you. Next slide. Yes.
So as you're moving through this, there are 3 members who I alluded to earlier who are your leadership team, and they're going to be listening. So they're not going to present until the very end. I think, I'm trying to remember what the third role was, but it's our teacher's assistant, a family member, and a new physician role, so the developmental pediatrician. And so for you 3 that are on the leadership team, please be listening carefully to what's presented, because you're going to gather information that's beyond what was presented in the case study. And then we'll help kind of guide the discussion, but we're going to leave it to you to help summarize what you've heard and maybe ask some clarifying questions to develop a treatment plan. So at this point, we're ready for our medical care team A. Can I get a volunteer from that team to talk about what how you answered your questions for Janie?
Yes, hi, I'm Steve, and I volunteered to be the spokesperson for our team. I'm the policy maker. That's my role. And just a moment, I'm gonna bring up the slide. Mike, are you putting our slides up as
Yes.
as we're doing this? Okay.
Yeah. Sorry, all the team slides are built into the presentation, so you don't need to share anything. You're fine.
Oh, okay, great.
Yeah.
Okay, so as I said, I'm the policy maker, but I'll be speaking for all 3 of us. So the primary care provider, and I should say the first question we had was about addressing her stomach concerns. So the PCP would have knowledge about the ketogenic diet, but it would likely be a good idea to ask Janie and her mother about fiber and water intake, and possibly refer them to a dietitian for recommendations about managing constipation, if that's not an area that's within the regular scope of practice of the PCP, especially with the ketogenic diet. Just to go rather quickly here, the family member, it would be good for them to work with the PCP, maybe do create a routine, a more structured routine to help with the stomach aches and possible anxiety on weekdays, since they seem to be occurring mostly during the times that she would be going to school, and also possibly meet with a dietitian. Myself, the policymaker, I would be working with this family to gather more information and lobby other legislators, like for example, the chairman of the committee that oversees DHHS, or multiple committees that oversee that agency, to advocate for raising or lifting caps on services that are paid for by insurance, as well as to try to remove some red tape that slows down the process, like families having to call multiple different numbers at the insurance company, being transferred multiple times. Those are all barriers to getting proper care. Medical factors, the primary care doctor, if with the ketogenic diet, the other first line defenses weren't working for constipation, they might refer out to a GI. Make sure they're monitoring regular blood work, especially blood sugar, cholesterol, order electrolyte, and metabolic panels, maybe do X-rays just to rule out blockages. Family member might be helpful for them to keep a diary of Jamie's symptoms and the diet that she the foods that she ate that day. So it'd be kind of like an ABC data chart, the antecedent being the food, and the consequences would be whether or not she had a bowel movement, and if so, what kind it was. And that would be to give baseline data, and the policymaker could consider whether current state and federal insurance mandates even allow families access to the specialists to make all of the rule outs that might be necessary in this case. I apologize, I'm probably going over our time, so I'll finish quickly. Insurance and policy factors. The PCP would want to prioritize referrals, since there could be many potential ones. Talk about children's special health care, possibly the children's waiver program for autism and healthy kids as well. Family member and the policymaker could work closely to advocate for services for children with multiple diagnoses, and work to see what appointments are the highest priority, to focus on helping families get access to those first. I think I'll end that there.
All right.
Nicely done.
Thank you, Steve. Thank you, Kristen and Alexandra. And I'm sure the person that assisted you all with the primary care was glad to do that. So thank you.
Thank you.
We'll move to the next slide.
And just so you know, we're going to move through a couple slides and then we can kind of pause and let any other comments or any questions from our leadership team kind of burble up. But for right now, let's move on to Team B and hear what our outpatient therapy team has to say.
Next slide.
Do we have a volunteer from Team B to start the conversation?
Hi, can you hear me?
Yep, thank you.
Oh, great. Okay, Megan, is it okay if we just all read our own?
Yep, go for it.
Okay, great. So with Kristen's help, I was thinking like a social worker, and was thinking that motivational interviewing, especially with the parents, might be helpful to keep the patient adhering to her diet. And then we wanted to address the social support available to the parents.
Mike, we are getting an echo from somebody's mic.
Yeah, it's just background noise from Isabel's. It's
Okay.
nothing
All right.
to do. No, keep going, Isabel.
Sorry, Elizabeth.
Sorry. I'll try to be quick. And then we wanted to look at social support for the parents, especially regarding stress, anxiety, and depression, because we know that the rates of those conditions are higher in children or in parents of children with disabilities, especially with PTSD. We wanted to think of ways of addressing those situations in terms of support groups or respite care options, and think about therapy options for parents and what was available. We were thinking about the child's vague complaints of illness and gastrointestinal upset, and we thought that sounded a little bit like we should look into the child's anxiety, look for patterns and when the pain occurs, and when her stress levels are high.
Great. So it sounds like you're also noticing some of the anxiety potential that Steve also summarized.
So next, I'm the occupational therapist. The biggest thing for the OT that we would be addressing would be working on some feeding therapy strategies to improve that diet compliance. So teaching parents strategies to improve interactions with foods, starting with probably some non-eating strategies so that she can just have positive interactions with those foods, reduce the anxiety and aggression around that whole experience, and then kind of work towards improving that diet compliance and improving her comfort and kind of that sensory piece of her diet.
Sure, that makes sense. From speech pathology?
All right. My name is Michael, and I'm playing the role of speech and language pathologist. So what I would be looking at here would be conducting an assessment of language and communication skills to assess where she's at and what deficits or skills need to be built upon, including social communication skills. Be assessing for the need for and requirements to see if a augmentative and alternative communication device would be something we'd want to recommend, and also if that was something that we decided to go to or go with, we'd want to provide training to the aide and the family for use of that as well. We'd also be developing a treatment plans for speech and language, social language, literacy development, self-regulatory and social interaction goals, which would hopefully work towards integrating Janie into participating in mainstream curriculum. Another thing we'd want to look at would be a dysphagia therapy program to address the possibility of issues with swallowing and feeding to make sure that everything's working properly there. So that's it from the SLP side.
Okay,
Next team.
so let's do the next team, our dentistry group.
I can start by talking about dentistry. I'm Bree. I am playing the role of the dentist today. I think, a primary goal that we had talked about was working to build Janie's comfort with dentistry and the dental setting. So helping to use short, brief sessions to have her come sit in the chair, become more comfortable with the sights and sounds of the dental office. When we did get a look in Janie's mouth, we also had concern that there was significant tooth decay and gum disease. And so part of our intervention plan will be around targeting for oral hygiene, perhaps working with other members of our care team to make her more comfortable with regular oral hygiene practices. And then we also, because of the significant hygiene and cavities, we thought that it could be possible that pain could be contributing to her resistance to working with dentistry in general.
Thank you.
Sarah?
I had the role of the family member. One of the big things that we wanted to consider was what the actual goals for the child were at this time. A lot of frustration over the difficulty assisting with brushing. We're trying to get the child to eat, and what might be concerning for that with the dentistry itself. We had concern for obviously Janie's oral health and her pain management that might come from not being able to have that successive dentistry experience, and just kind of what the overall goals were for her hygiene and the ability to place items in Janie's mouth to continue that good oral hygiene and be able to do what is necessary for her to better herself.
Great. And we have a psychologist helping on this too, right?
Yep. So I'm playing the role of the psychologist, and so we figured out that Janie has some weaknesses in her attention and problem solving and overall communication. So we would be utilizing the therapy sessions that she would have with her psychologist in order to try to, I'm sorry, I'm getting a call, to try to increase her attention span so that she can pay attention to some of the commands so that she can be in a safe environment when she's at the dentist. We would also use therapy sessions in order to desensitize her with maybe YouTube videos. And I recently found this machine that would kind of give stimulation to patients with autism spectrum disorder. And we can incorporate that as well. So definitely setting goals in order to increase her attention and focus on her strengths, and even using some nonverbal communication methods and incorporating that, and maybe bring that into the appointment so that she can communicate with the dentist and other strangers that she might be new to, or new settings that she might be new to.
Thank you. Can we go back to the slide with the case and allow team F to ask questions?
So our leadership team, do you have any questions from any of the 3 smaller reporting teams that you just heard from at this time?
Hi. So with the dentistry team that they just talked about, they talked about desensitization and increasing attention. Can that be done done together with some of the other professionals that discussed, such as OT and SLP?
I think definitely bringing together the different professions in order to try to coordinate subsequent visits and then create the same goals, and then approaching it from different angles would be ideal.
And you mentioned a program that you found recently. Can you share that with Team F?
Yeah, I would love to. It was a machine, but I actually forgot the name of it. But I will do my research and try to find it.
You can send it after. It's okay.
Sure.
Just didn't want to forget that.
It's a pretty expensive machine, and I think it runs around $20,000. So it's not accessible in a way, but it is something that is a resource.
And I'm wondering if either our OT or our speech pathologist who just presented, what's your reaction to this idea of incorporating some of the desensitization?
I think that makes a lot of sense from the OT perspective, because we're working really towards similar goals of being able to get different things into her mouth and have her be more comfortable with that experience. So a lot of the different like feeding therapy strategies could probably be used with different like dentistry tools and things as well.
If there's any other burning question from Team F, can you ask it now? Otherwise, we're going to move to the next group, which is D.
I guess my other question would be, do we have a way for Janie to like be expressing if she's in pain? Like we said possibly like she was having some tooth problems, so like expressing that, as well as even like her stomach pain. Like since her expressive skills are limited, do we have like visuals or something that she can use to express when she is in pain?
I can talk about that from the dentistry side. We had talked about using nonverbal indicators of pain as a way to monitor her response and her pain tolerance and her pain in the context of her dental visit. So we would be looking at things like face, leg, arm, crying, those kinds of things, movement, in order to see if she's in pain.
I think that's a really great question to move us forward actually to the next team presentations. So we're on team D, is that right? And yep, this is our nutrition team. So they've been working with Janie at the school primarily. And do we have somebody who's willing to kick it off from this team?
Yeah, this is Natalie, and we had a dietitian, a nurse, school nurse, and the teacher's aide. So we definitely want they're going to work as a team, obviously, the nurse and the teacher. The teacher needs to work with the aide because they're using food as a motivating factor, so including like candy and goldfish, which is obviously not on a ketogenic diet. So we're going to have to fade the usage of food as a reward for non-preferred activities, and providing recommendations of foods that can be added or omitted. We would wanted to get involved with, so the dietitian could find out what foods Janie is able to eat off the current school lunch menu, because we're not sure that she's eating the foods that are good on the ketogenic diet. Helping the lunch staff with the selection. The nurse would have to check her blood sugar levels regularly to monitor her progress. We would fade from the food driven rewards, to like a picture schedule, new incentives, maybe a visual system, sticker system to reward her. We want to implement a nutrition diary so Janie can develop an understanding of her own food intake during the school day and allow her to be part of the tracking so she can learn. The sticker system, again, can be utilized as a reward. That's an option. And send the diary home to the family, too. And we want to track what she's eating at home as well, so that we can have some carryover. Anybody else on the team have input?
Really nicely summarized. For time, we're going to move through the last team presentation, and then we'll kick it back to you, leadership team, to ask any clarifying questions you have. So this is our school communication team.
I'm Libby.
Oh, great. Sorry.
Sorry. I'm Libby. I took on the role as the audiologist. And so the question that we were asked was, what kind of recommendations would we give for figuring out her hearing abilities? An audiologist would do, to backtrack a little bit, the information we were given is that she's already had formal assessments and they came back inconclusive due to some non-compliance. So the next step could be conditioned play audiometry. And this is it's a formal assessment, but in this type of assessment, they will signal that they're hearing a tone by, for example, placing a ball into a bucket. And this is more play or more stimulable for her. Use with headphones so you can acquire ear-specific information. You could also conduct an informal hearing evaluation, and this would be just interviewing the teachers and parents for information on what they think she hears, and what noise levels she appears to hear in, or other pertinent information. And if all else fails, a sedated auditory brainstem response evaluation would be necessary to determine her hearing thresholds. But other things that could be done to increase her chances of hearing would be to give her preferential seating in the classroom so she is closer to the teacher. This gives her better vision and better hearing. Also could use an FM system with headphones and reducing the acoustical vibrations in the classroom by adding paneling to the ceilings, carpet, and then reducing the background noise.
Great.
Yeah. Does our speech pathologist want to jump in?
I don't think she's actually here. So
Yeah, no, Alexis wasn't able to join tonight.
Okay.
Jenny, I think you're on those emails.
Yeah.
Okay, I can do that.
Yeah, she did mention one of you was taking on her role, so go ahead.
Oh, okay. So Alexis filled out the portion for the speech and language pathologist, and ideally the SLP would want to know the hearing abilities beforehand, but they can also do a screener if she's compliant for the screener, and they could also refer to an audiologist. An SLP would want to determine receptive and expressive language skills by performing a language sample, and this is really more so direct observation of Janie, and then engage with her in an environment where she's comfortable, and this will give her the SLP information on what she understands, how is she communicating, and then the SLP may also give parents an informal interview, just again gauging what she can do and what she understands. There's also standardized assessments that parents can fill out, as well as teachers, that give perspective on the communication skills. And one example is the Children's Communication Checklist 2, and that also has norms on it. An SLP would perform more assessments, and these would be the standardized assessments to determine receptive and expressive language. And then I cut off a little bit at the bottom, but the SLP would really want to figure out her stimulability for AAC use, what kind of AAC would be the best for her, whether it be a communication board or a speech generating device, and then how it's organized. And yeah, I think that's what she has down at the bottom.
Libby, and I know you didn't do this one, but can you provide a little bit more information on the performance assessments so that the leadership team can have some information when they're presenting?
So the standardized assessments?
Yes.
So the OWLS and the Peabody picture test, those are both receptive language. So this is where you would assess what the child does understand. So I know in the OWLS, if you show the child a picture and ask them, can you point to the ball or point to the color red, this is where they would see this is where the SLP would see what they're understanding. The expressive abilities are also assessed in the OWLS, and this is where they would be asking the child to say something, to identify something verbally.
Thank you.
You're welcome.
Megan?
Yeah, as so as a policymaker, it's important to us that each of a child's accommodations are considered, that the IEP isn't sort of pigeonholed for just one diagnosis, but that each diagnosis is taken into consideration. We'd also want to ensure that assistive augmentative communication devices are available as possible, that district funds aren't the limitation there, and that the same device is able to be used at home and at school, so it generalizes appropriately. And then we'd want special education consultation services where parents can call and receive suggestions relative to their IEP and accommodations that are available. And then we'd want families to have access to a list of free education, advocacy, and legal resources in case there's IEP disagreements.
Are really important in this case. So at this point, we can go to the next slide. I'm sorry, I think this might be, go ahead and advance again. Is this somebody else? That might be an old slide that snuck in on me. So at this point, let's go ahead to our leadership team. I think now you've had all of the information. Yep, we're there. Presented. And so actually, if you can go back one more, let's kind of go through our leadership team and let them ask any questions of other team members that they still have. Why don't we go ahead and start with Carrie, our developmental and behavioral pediatrician. Do you have any kind of clarifying questions or thoughts that you need to gather information about?
So I guess for the medical team, my question would be if there are any programs or policies that they have looked into from like a hospital or facility standpoint that could be used to better inform the people working with Janie on how to work with patients with disabilities.
This is Kristen. I played the primary care provider role on that team, and that is not something we talked about, but that would be a good suggestion. Thank you.
That's all I have right now.
Okay. Any questions, Andrea, as a family member?
Not particularly.
Okay. And Haley, did you have any kind of lingering questions for any of the team members?
I guess just, do we have a way or a plan in place for within the schools of when she is experiencing pain, and for if she does have her seizures, like, do we have a plan laid out for what the steps would be and who's to be contacted?
That's a great question. Does anybody have information they could contribute to that?
Yeah, so as a school nurse, she has her IEP seizure emergency plan that is shared with the teachers. And I think what the dentistry had mentioned, great with the whole visual pain scale. I think that would also be great to implement in the IEP seizure plan that the nurse has in place. So again, monitor her pain scale.
And it looks like in our chat box, some people have been pulling up and sharing some examples of that. So you have some current references going around. I'm going to put our leadership team a little bit on the spot now and ask each one of you to sort of summarize. Each one of you had a piece that you were focused on in terms of questions. And if you can advance to the next slide now. I'll have you take turns first summarizing what you're hearing for Janie's care team needs, and then proposing really briefly, what do you think are the most important treatment recommendations that you have for Janie? And one of the things that we're up against is there's a ton of information here, but I think it was Steve who mentioned really adequate or really appropriately that we're not going to be able to do everything. So try and limit your recommendations to one or two things each that you see as the most important next steps. Does anybody feel ready to start, or do you need a minute?
I think I can start.
All right, who do I have? I'm sorry, I can't see you.
Sorry. I'm the developmental behavioral pediatrician.
Okay. Perfect.
So it sounded like there was a lot of overlap between the different teams, which is good. I think I would start by saying we need to share, come up with a nonverbal pain scale that we think will work for Janie, and share it across all teams so that everyone is using the same pain scale, so that that's consistent for her. I think that would make it easier for her and her family. I also think there needs, as far as the policy goes, I think there are some resources that we could implement, like at the hospital level. One from Boston Medical Center is called the Autism Initiative or something, I believe. And they have basically some resources for doctors and health professionals and hospitals as a whole to kind of use and implement in working with people with autism. They also have some health social stories that we might come in handy for Janie as kind of a visual aid or a communication aid for her, to kind of prepare her for all of these assessments and therapies that she will be going through. Let's see. I think the AAC across teams is going to be important. So making sure that a specific communication device is chosen, and that all teams are trained on how to communicate with Janie through that device, whether it's PEX or a more iPad digital version. And I think that's all I have for now.
So really focusing around helping improve her communication and what that looks like, especially in the medical settings.
Yes.
Do you recommend that that they use some of these tools, sharing it with the family?
Sharing, I'm sorry, say that again.
Do you recommend using some of the assessment tools for the family to have, so that when she comes in, she's not so scared about responding?
Yeah, I'm not sure which assessment tools you're referring to, but obviously I think the family would need to be involved at every level. So any training that the teams undergo on the AAC, for example, I think the family, that opportunity should be given to the family as well.
Yeah, sure. Thank you.
Speaking of the family, Andy, do you want to summarize what you're hearing as a family member?
So as a family member, I'm hearing a lot in a lot of technical terms that I most likely would not know. So I know the prompt said to focus on the team B, the outpatient therapy and the communication teams, especially for Janie's needs in the school setting and what I think she needs in the school setting. So what I'm hearing from them is that she needs sensory desensitization training along with that communication device, and that to, again, be across settings. And then the communication team, I heard the same thing of really getting that testing done to see where her hearing is, but also getting that communication device in place so that Janie can communicate with everyone that she interacts with about the pain which has been discussed. As a parent, I would want training on that AAC, or family member, I would want training on that AAC device, along with a kind of summary of what's happening in each of Janie's therapies, just because it's a lot.
Absolutely. And it sounds like you're trying to keep track of a lot of pieces.
Yeah.
Yeah. So we have one other professional really hoping to help pin down her school plan here. Haley, our teaching assistant, what are you hearing?
So I'm hearing a lot about like the communication and again the hearing, which I know we've like touched on, but really I think it would be very important to figure out the hearing and then as soon as possible get some of those supports in place so that she is able to be hearing what's going on, to aid in her communication, as well as determining like if we're going to use an AAC device and which would be the best fit for her, and then also like visuals within the classroom and within all of her environments within the school. So like making sure all the professionals are using consistent visuals and visual schedules. And then within these, or with the nonverbal scale, like again, making sure she can indicate pain and is able to do that. So I think through the assessment too, it might be good to assess if she is able to, even nonverbally or with like a device, indicate her pain accurately, and see where she's at with that. And then with her strict diet, I think especially as like the teacher aide, it'd be important to make sure she's sticking to this diet and think about ways that like during holiday parties or if someone's having a birthday and brings in snack, like finding ways for her to be involved, but like sticking to her diet and making sure she is sticking to what is in place and the plan that's in place with that.
Haley, one of the teams recommended feeding therapy as a teaching assistant. Do you think that's feasible?
I think it is feasible potentially, but well, and as my role, I guess, I don't know. But as a speech pathologist, it would have to be, as a speech pathologist, working with feeding in the schools, it would have to be, the actual feeding would have to be impacting her education. So if if that wasn't, then she wouldn't be able to, or a speech pathologist wouldn't be able to work in the feeding aspect of that. But if she isn't able to, with modified diets, eat anything during school, then she's not going to have enough nutrition, and then it is going to impact her education. So I guess it's figuring out that fine line of if we are able to do feeding therapy in the schools, because definitely could be beneficial if she's.
Sorry, I didn't mean to talk over you. It sounds like there's pretty high agreement on our leadership team that getting a solid communication strategy and a communication device is among the top recommendations. And then further evaluation of hearing is also really high. I'm going to kind of kick it to Andy and Carrie too. Does feeding sound like the right third recommendation, or is there anything else that you think we'd want to address first?
Yeah, I think so. One of the themes that I took notes on was food diary was mentioned several times. And that's another thing that I think we should try to keep consistent across teams. So making sure everyone is using the same format, and then communicating that to the family so the family's able to use the same food diary as the school and the outpatient setting, and that kind of gets cross-trained across everyone. And then there was another thing that kind of goes along with being able to communicate pain, looking into interoception resources. There's a book out there by Kelly Mahler, and she does some great workshops and things to try to get kids with autism to better communicate how they feel and explain their pain better. And so I think that is an important piece also.
Mm-hmm.
Yeah, I would add to that, with the how you feel, the emphasis of emotions too, and giving her access to explain her emotions, because I know they said she did have problems expressing emotions, and if there is the potential for her to have anxiety, which might be causing some of her pain, then I think that, again, that would be a really important thing to focus on as well within the communication devices that we're implementing.
That's a really excellent point. There was a lot of mention early on about how anxiety could be affecting her symptom presentation, as well as her pain, as well as her school performance. I'm watching the clock here, and I think we're going to have to cut the discussion.
There's a question. Who is supposed to be training parents didn't know how to use a school device?
So, yeah, there's a really good question that's come across the chat of who trains parents on a communication device. So any last comments from the team or from our leadership team about, and actually this may be some of our specialists who can answer this the best. We've got Janie working with a speech pathologist outpatient, working with a speech pathologist at the school, and then her family needs to be looped in. How would we do that? Who's a good point person to try and talk to our confused family member over there?
I think that SLPs should both work together and then work with the family. And then there's also some individual, there's some nonprofit organizations that provide training on AAC devices and software as well.
In terms of payment for that, do you think we need legislation?
Absolutely.
So for time, like I said, I'm going to wrap up just a little bit. I think you've done an excellent job summarizing her care needs and trying to condense a huge amount of information. So just last comments on Janie, you've got a really large and really detailed and expert treatment team here. So each of these presentations had a lot of valuable information in it. I want to just highlight again Andy's comment that as a family member it can be really overwhelming and potentially really confusing. But our leadership team did a really nice job of highlighting what Jenny and I have embedded as some of the key issues. Understanding communication and understanding how that is important to help her communicate both pain and feelings, fear, anxiety, etc. Understanding how her diet can complicate her medical picture and how non-compliance with her diet really may be underlying some of her other medical needs. And then lastly, talking about how her therapy teams, if they're not coordinating care closely, might actually be creating more confusion or adding kind of disparate goals into the mix. So I actually think you've summarized really well an appropriate plan of action for Jamie.
I'm doing that on the fly. That's pretty good.
You guys almost have done your homework.
Yeah.
So let's go ahead and advance to the next slide.
22. Slide 22.
And you can all kind of shake it off and adopt your real professional roles now. You no longer have to stay in character. You've all made it to the end.
The next slide. Yes. We're opening this up to each of you to give us some feedback on what your understanding of a change in role was, and what are your attitudes that you had about working with an interprofessional team. Many of them you have met in the face-to-face, but not had to have to work together on something in a different role. So I'd like to hear your comments on that. We'd start with in team A. Anybody from team A wants to start?
I can make a comment really quick as just thinking as or trying to think as a policymaker, which I have no
experience. Oh, you don't have to be a policymaker anymore. You can just be Steve.
Oh, okay, yeah. So, well, yeah, thinking about both roles, I guess, at the same time, is kind of interesting that, you know, from being a behavior analyst, I think about what is clinically appropriate, of course, and socially valid for the kids and the families that I work with, versus, you know, like a policymaker role where the question that kept coming to my mind was, you know, how will this be paid for? You know, what state resources are going to be used, which, you know, is not something I normally think about, and I'm kind of glad for that, but that's just what I found.
Sure, so it was difficult to think on both levels.
Yeah.
Did anybody else have that sort of experience? All right, in this case, we'll kind of call on folks from Team B, any volunteers from Team B that want to talk about sort of either how your attitude and feeling about this was or what you noticed.
I'll share. So I had the role of OT, and it was more in the outpatient setting. And then in real life, I'm an SLP. And so I think something that I kept coming back to was like, how do we do this in real life, right? Like the realities of like caseloads and just like time and finding a way to just connect with all of the members of the teams is kind of overwhelming, both from the OT outpatient perspective and then also from the school SLP perspective, because there's all of these roles that you already have. You're seeing, you know, 50 some kids, and then like, how do you connect with all of these other professionals that are involved? Because it's obviously so important.
That's a really great point.
Megan, I like that you said the SLP should be doing the training with the families to incorporate AAC, but do you see that as time constraints too?
Yes. So I work with a lot of students who use AAC. That's the majority of my caseload. And that's probably my biggest struggle as a professional, is figuring out, okay, do I go see the student today, or am I going to try and contact their parents and do some parent training? Because there's just not enough time in the day to do it the way that I would like to do it, the way that it should be done.
Mm-hmm. Is there anybody else you could get help with to assist you?
I think classroom teachers. I'm an SLP in the schools, so classroom teachers a lot of times have a much closer relationship with their students' families, just because it's like every single day they're communicating back and forth. And so that, I think, is a good tool to, like, if you can pass information to the teacher, then they can kind of send that out one by one, more individually.
Is this something we could create for the teacher's aid to use, since a classroom teacher might be as busy?
Potentially, yes.
Team C? Go to Team C?
Team C, the dentists.
Yes.
Sorry.
Yeah, sorry.
Okay, I was just going to look it up on someone.
Forgot which letter we were. I thought that, Jan and I had opposite roles from our usual lives in this
did that
module. It was really interesting. I think I was struck by how much overlap there is in the types of approaches that dentists use than that we would use as psychologists, and kind of using graduated exposure to just to a stimulus that makes the child fearful or uncomfortable. So I thought that I was impressed by how compatible our approaches were.
That's great.
Yeah, I agree. I think just learning about what the other profession did was really interesting. And once we got on the same page that this was like a desensitization approach, I think we figured out like how to set goals for the patient and then proceed from there.
Yeah, it's interesting to find the commonalities and two really very different specialties on their surface, right? Team D, any observations?
I guess for me, it was very eye-opening, as a professional, receiving all the information from what others would recommend was insightful in a way that I can modify how I do testing, but then just thinking from the parent's perspective, if I felt overwhelmed, I can only imagine what the family members would feel. Like if I'm like, okay, I got to take into account SLP, PT, dentistry, their recommendations on how I would factor that in is just a lot of information. And I think just when it's coming, that's when I think coming up with a cohesive plan across professionals is truly best practice. And I can't imagine it being done if the professionals are communicating. Just sending different information to the parents would be a lot, I think. And that was my takeaway.
Well, I think that's a really excellent point. This is something that I think many of you know happens in real life interprofessional teams all the time. We as professionals sort of feel pulled, and I noticed this with many of your reports, we want to show that what we know, and you've done a lot of research into somebody else's profession, and so you're giving a lot of important details about how someone could approach this problem. But you're right, it's really easy to lose the most important messages in too much detail if everyone does that in a team meeting. One of the most challenging things in our team meetings in my real life is to distill the most important information for the whole team to hear. And so I think your observation is a really important one for how to be good at interprofessional practice. It's not just to know and respect what the other disciplines are doing, it's also to be able to edit and really cut to the quick of the most important stuff.
Any volunteers from Team E?
That is our school nutrition plan team, I think.
Oh, I thought we were D.
Did I say that wrong? I might have. I'm having slight issues. Yeah, Team E is our communications plan, sorry. School communication team. Any observations?
That was my observation. I think I talked from the wrong letter.
Oh,
That's okay. We'll go back to D.
I think it's interesting as a DBP how some of the same issues that we see came up, that it's the sharing of both the school and the parent using augmented communication devices, and that feeding is always something that seems to come up, because I think that my focus area is premature kids, and a lot of times I think that for parents that's something that they view as a really normalizing kind of family activity, so that's really important. But I think I've noticed too that care gaps with patients tend to be where two disciplines overlap. So like pain management or feeding or how to do communication between school and home. So I thought this was pretty representative of some of the things that we hear in an office visit.
Mm-hmm. And that's a good thing and a bad thing, right? I'm glad to hear that this has some themes that ring true. The downside for those of you that are sitting and waiting for the simple answer for the part of this lecture where I tell you how to solve this problem, that's the downside of this. These are not easy systems to solve. And I think some of Jenny and my main goals in doing this exercise is to highlight what's difficult, because presenting what interprofessional practice should look like is a lot of facts and a lot of aspirational thinking. But in reality, I think you're exactly right, Megan. This is something that's really difficult to find the time to do in practice. And I've heard that theme from several people.
And it doesn't matter which discipline you're from, you'll have the same kind of issues come up. It's always either billing time for yourself or billing time for the families to get reimbursed. So, yeah.
So let's go ahead and advance another slide. We have about 20 minutes here, and I think we have a few more prompt questions, but I'd actually just be willing to open it up for discussion in a larger sense. Do people have questions or concerns?
I think one thing I observed through this process is that's representative of real life too, is that people come to the table with different priorities and different pieces of information too. And so when we all had specific information that even others in our small group didn't have, it required like a lot of communication about that because we all had different priorities. And so trying to come up with a plan that incorporates all that information that individuals have, but that kind of focuses on, narrowing it down. Like you said, we can't do all of those things. So what can we prioritize and come together in agreement on?
That's a really good point. One of the things that if at the end of this talk, you're going to see we have a lot of informational slides that we haven't really spent time presenting to you today. But what you'll see is there's a huge emphasis on communication. And so anything that you read that talks about interprofessional teams or interprofessional practice talks about the need for collaborative communication. And in practice, what we often see is exactly what you're bringing up, which is that people are coming from their own perspective, and it's really hard to slow down enough to listen for what that communication breakdown is, or try to understand what information somebody else is bringing to the table that's driving their questions and their line of thinking. And so one thing that we try to do, and I think this group actually did a really excellent job of, is listening for what doesn't make sense or what someone's presenting that might not sound like what you thought, and then trying to clarify that question. And that sounds like a simple thing to do, but in practice it can be really challenging. And that's why you hear it talked about again and again and again in interprofessional practice.
And a lot of times it happens in a group setting, and people are bashful about opening up and saying something because they feel the other discipline might be annoyed or get upset. And so it's important to have some ground rules and letting people know it's not anything directly related to the person that is speaking, but it's more in terms of trying to make sure that the patient is getting what we wanted them to get from this treatment plan that we put together. So looking back at our group here and some of the goals for the Michigan Blend, we have life considerations. I go to that next slide. And any one of you feel free to let us know your thoughts of what you saw today in terms of your role, either in leadership, interdisciplinary, family-centered care, or equity. And I know we have a couple other people that are not necessarily trainees, but who might be wanting to say something. Please let Mike know, and we'll take you in at this time too.
I actually have a question. So I don't work in healthcare, I work in research, and I have an education background, but I was just wondering,
Can you just say your name because we can't see everybody?
Oh, yeah, sorry. This is Carrie. I was on the leader.
Go ahead, yeah.
What are the chances of all of these different teams actually ever coming together and communicating with one another?
So
I've never seen that happen.
Well, so I will tell you, in practice, it's really, really hard. What is very real is this example of a case. So this is developed on not one specific person, but she's very representative of the kind of patients that I see and that I think many of our faculty in the LEND program see. And so having this number of specialists is not uncommon. Having the kind of forum where all of them would be able to talk at the same time is very rare. I think what you're much more likely to see is something akin to the small groups that you worked in. And then to truly be an interprofessional team, a lot of virtual communication is what ends up happening. And that's the other kind of nice thing about this model tonight is, you know, it may feel clunky and weird to be doing this on a Zoom session, but in reality, that's about the only way that this wide of a group would ever happen.
Yeah.
I'm curious, other professionals on this call work in teams all the time. Has anyone had a team this large in their professional life?
I think at the U of M, I know Bree can speak to it too, but the Cleft Lip Cleft Palate Clinic actually has a lot of different specialties working on it, and they regularly meet on Wednesdays, I believe, just to speak about patients and the caseloads, and they encompass a good amount of professions, including medical, dental, different specialties of dental, ear, nose, throat, speech path, plastic surgery, stuff like that. So, and this is common in a lot of different states. I've been to a couple different schools and different hospitals, and it seems like there are a lot of teams that are in place to manage specifically this population.
And do you know, have you been able to sit in on those team meetings? Do you know who it would be that would follow up with school if there were school questions or problems?
School would probably be outside of the regular. I don't know any profession that specifically touches that school aspect of it. I know a lot of the professionals would have access to the parents, and so they would try to advocate through the parents, but not specifically school.
Yeah, I think that's one of the common areas where breakdown happens. That's one thing that I think is unique about this case study is that we tried to get both school and the outpatient world together. And most likely on that team, it's going to be the social worker that's going to make that extra point of contact and try and help advocate for the families. But I think you're right. The craniofacial team at Michigan is an excellent example of a large, really highly functioning interprofessional team.
Yeah. I think Steve said ABA also sometimes collaborates with the schools.
Yeah.
So, yep.
And we definitely have some other ABA specialists in this group that may be able to speak to that better than I can, how that looks in the school environment.
So I currently work at a CMH, and we have weekly meetings that are fairly representative of many of the disciplines that are here and that were discussed tonight. It would be nice to incorporate a little bit more integration between the CMH and the school versus just sort of compartmentalizing, our assets and in those meetings. So, moving forward, it could be something to look into, possibly having a representative from the school. It's a smaller town too, where, most of the children we see at the CMH and the cases that are discussed at these meetings all go to the same school. So it would completely make sense to have a representative there. So.
And I can see many of you are participating really nicely on the chat on the side, and a lot of really great real world points are being brought up. I'm going to rewind back to something that Kristen mentioned, which is that, if you have somebody who needs an AAC device and the training goes across all professionals but doesn't go to the parent, you've got a really expensive paperweight on your hands. I thought that was very well said. The point about parent training and how that fits in medical care falls in a similar place to some of these interprofessional conversations. How do we get in touch with a school if the school is not representative? Or how do we get in touch with a different therapist who's not able to attend a team meeting? The reality is these things are hard to pull off because they're not billable and because they're things that aren't going to be reinforced in most professional settings in a way that really captures your time. And so that's, I think when we talk about interprofessional values, that's a real crunch and that's a real barrier that you're going to run into in your professional career. Having a team meeting is a really efficient way to transfer a lot of information if you can find the protected time to do it. But the other thing, that we really are sort of charged with as professionals is trying to find efficient ways to make your notes as readable to others as possible, and being willing to make those follow-up phone calls or sit with a parent and carve out that time. And in a lot of cases that falls under the work that we don't think we do, but if we're going to provide patient-centered and interdisciplinary care, we really need to do. So that's my soapbox.
Yes. Can we go to the next slide? Did any of you feel that you were introverts or extroverts on the team and someone had to ask someone a couple times to do this? You don't have to respond to this question. You can always send an email later to us. We just wanted to know if there were any roles or people on the team that felt that they couldn't respond because they're more of an introvert, didn't feel comfortable being out there and typing up something in relationship to a role that they are not comfortable with. So we don't want you to have to give us feedback verbally, but you can send us a comment later to both of our emails. Were on all the emails that you got for the case. So feel free, or the first slide has our emails on it too. So we'd like you to use the opportunity then. We have about 10 minutes left, and I'd like to go to one slide, the next one here. And this things that you all brought up here because of different points of view, but I think with the family, the last one was more important in terms of the cost for care. And looking at the life module that you have for Michigan Lend, that is one of the biggest deterrents when we're providing care is the cost. And the reason we had two of you perform in the role of advocates or legislators or trying to get something passed in the legislation was mostly due to this last one on cost of care. Anybody wants to comment on that or have any last comments that you have? We wanted to give you guys the last few minutes to share anything else you wanted to. And there are more slides here. There are about, I think, another 9 slides, and Mike will be posting these, so you'll get all of those later. Let's go back to that last slide. Yeah, thank you.
I'm just noticing, I think it was Isabella that commented that she's seen folks without billable services call into school meetings. I think that's, to echo Carrie, rare, I'm sure, but excellent, right? This is the kind of stuff that that is valuable and that we hear from families all the time is important to their care and is the kind of services they want. Going back to Jenny's point about the need for advocacy and the need for legislation, these are exactly the kinds of services that are getting harder and harder to justify in our current medical system.
I was noticing, not in this program, but I also do some work with Alzheimer's, and now Medicare is actually paying for adult daycare reimbursement services so you can have some respite. And I think maybe some of that should overflow here too in terms of advocacy. And if we got it in one level, why can't we get it to another disability here?
Are there any questions that folks have for Jenny and I before we wrap up tonight? In that case, I think what we can do is give you the gift of time, the last 6 or 7 minutes here.
Can you go to slide 28, please? 28, yeah. But just that one, go back up one. We wanted to leave this slide for you to think about as you end the day today here with us, that these are the domains that you need to keep in mind while you're working in a team. Your roles, your values, your communication, and most important, it's teamwork that will get something done. So we appreciate what you did in terms of putting the case responses together. And I think you did address all 4 of those areas that we were looking for.
Absolutely.
So nice job.
And feel free to continue this awesome Zoom group chat on the side.
Yeah. Mike, if there's nothing else, we can end it here and you can post the slides.
Sure. Yeah, thank you. And thank you, Jenny and Abby, for leading the session tonight. This tends to be one of my favorite ones every year, and y'all did a wonderful job. As Jenny mentioned, we'll be posting, I'll post the slides, the chat log, and the recording of tonight's session to Canvas under Module 3. That'll be up around Friday afternoon, just so y'all know. And as always, expect a link to an evaluation for the session tonight. We really do value your feedback. The evaluation will be open for 1 week and close on Monday night, Tuesday morning of next week. So if everyone's good to go, have a wonderful evening, and we will see you all next Friday on the 15th.
Thank you. Bye.
Thanks, everybody.
Thank you.
Have a good night.
Night.